I got to see some of the NYU graduates that I haven't seen for a very long time. I want to thank you all for having me here. It is a great opportunity to be with you and to share with you some of the things that we are doing. As Jaime mentioned, my career started as an educator. Even when I was a dental student, I wanted to teach because I felt very strongly that that's how I can actually expand my knowledge. So it was to start with a selfish reason. But also, eventually, I realized it's the only way that we can all get better. So I've been doing this a little bit longer than some of you here in the audience. So there are two major influencing factors in my life. One being at NYU for so many years. So those of you that have been there, like Jaime, I know that you do appreciate what NYU has done, and I know that they're here during this meeting. The other influencing factor is really my love for private practice and really feeling what I can do for a patient. And I'm fortunate enough, like probably some of you, that I was able to maintain these two careers going on all at the same time. Although today I don't teach formally in a university, I have university affiliations, but I do a lot of private teaching. That's where I spend most of my days. I work probably as hard as some of you do. This is our private center. My wife and I created that place, and the goal from day one was really education and what we do with education. But what I want to focus a little bit on is my title, Forward Thinking. While I stand over here and I know that you're hoping you're gonna leave with a couple of clinical tips. You say, okay, I will do this, and I will make sure that I will get to that. But more importantly, I think, what is it that you and we do every single day? I sat here for a little bit in the afternoon since I arrived, and I saw some amazing and beautiful dentistry. But I've learned over time that I really need to think a little bit more about the case, what happens to it long term. And in dentistry, we call this predictability, but I think of it slightly different, and you'll see why. When you look at this case, if you are an orthodontist in the audience, you would think we can bring the teeth together. If you are a periodontist, you see that there is some recession and some gingival problems. By the way, I do apologize. My voice is a little bit maybe off. I do have a slight cold. But I think the case is a lot more than just ortho and perio. If you look at the plaque accumulation, yes, it is plaque also, so we'll think microbiology. But we have to think of the patient as a whole. And if I told you that's how the patient came in, and actually the patient came in orthodontic treatments, you can see the brackets here. And the challenging part is, what do we do for a patient like this? Is this a true orthodontic patient? Because dentistry has a very major mechanical component. We're all very good at this. We like to use our hands, and we're very creative, and we think we can do some amazing stuff. And that's the mechanical event, and that's okay. But how do we step back a little bit and think slightly differently? So if I told you that I will take these teeth out, you can realize that the case actually becomes more complex. And now I have to think of bone metabolism and bone behavior and physiology and anatomy. So it is really true interdisciplinary all around. By the way, I already signed that this lecture can be on the website, so you can view it or you can take pictures, whichever you like. The challenge that I have is if we look at this and we say, or we do what we used to do, for many years, I will cut this bone here so I can get to a platform that actually is workable. And I think in Spain, no different than the United States, probably the concept of all-on-4 and bone reduction is a very popular concept. And I think we're going about this just the wrong way because we're just making sites a lot more challenging for patients. But I also can tell you, and I know, and I promise you that I will at the end of the lecture, I will tell you how we got from here to here, placing implants in areas that there was no buccal plate of bone, create a buccal volume that we believe is necessary and acceptable, and a buccal volume of soft tissue as well, and look at the pontic spaces as well. So I think that's very important that we can achieve that. But if I stand over here and I tell you that I can do all of this by myself, I would be lying to you. There's this amazing group of people that I have the opportunity to work with on a regular basis, that I interact with, and believe me, they influence my thinking every single day. Even at times when I'm thinking that, something can mechanically be achieved, I realize that actually we have to think totally different. And by the way, we have a goal as a team. As a team, we want to be a global leader for excellence in patient care, clinical training and education, and research. And we do this really every single day. And by the way, customer service. Customer service is an important factor in our practices. I know that that's not dentistry, but that's an important thing to keep in mind. That's what keeps our patient happy. And there are a few things that allow me to get there. I'm very fortunate to work with the finest clinicians, scientists, and educators. So that's a very unique opportunity for somebody like me. I had that when I was at NYU, and I have that today in my private center. I tell everybody, if you have a lot of technology, that sounds really good. Being high-tech is very important, but being high-touch is a lot more powerful. And I believe as much as we are high-tech, we are more of the high-touch concept. In our training program, we are 1-to-1 faculty-to-participant ratio, which is a very unique model, and we're very proud of it. To have a strong industry relationship is very important. A meeting like this with the leadership of Jaime and many of you will not happen unless there is a strong industry support. But we do this with the highest level of integrity and independence, and we have a tremendous commitment for excellence. I was outside with Kim Missevis from NYU. She's the director of the international programs now. And as I was reading the card, I do apologize, Kim, I didn't realize that actually NYU reaches 100 countries in the dental school, which is truly incredible. I'm way behind. I only reach about 38 countries myself, which you guys do an incredible job. I list this because I think it is very important for you that you know whatever I will tell you today, I'm not paid for. So that's a very important fact. But I do have an incredibly strong relationship with the industry, and I have been doing research for many of the companies as well, and we represent them in our center also. I got involved in the event because of Jaime and Omnia, so all of these companies I have worked with for many years. We have study clubs, we have restorative programs, and we have surgical programs as well. This is just kind of to show you the environment that actually I am in every single day. While implant dentistry kind of like doesn't really fit the profile of the operating room, one small advice, especially for the younger group in the audience, sterility and technique is incredibly important. I think you have to be very careful with that. These are some of our graduates at the center. And presently, I'm actually looking at potentially doing some programs in Guatemala, and we'll see how that goes. So what is forward thinking? So when I look at ridges that look like this, obviously there are few people that have been in that site before. So there is tremendous scar tissue, there is a ridge deficiency, and there are few problems that we're looking at. And if you look where this patient started here. So for me to sit here and be critical of what somebody did over here probably is truly unfair, because that's where she started. But nonetheless, somehow we managed her, dentistry managed her to function like this for a long time. And I also don't want to criticize this kind of dentistry, because it did serve people for a very long time, predictably as well. It may not be the most beautiful, but that's how this patient functioned. And I got to see this patient actually because a friend of mine was training somewhere in the west of United States, and almost experimenting, trying a block graft, trying particulate graft, and you see that there is absolutely no concept. This is This is pure mechanics, and that's not what dentistry should be. And that's when I talk about forward thinking. Somebody really didn't think very hard, what does it mean to harvest a block graft? What does it really mean to you? For some of you, it is the gold standard. It is autogenous bone. For others, it may not be the case, or they may not have the comfort in going to harvest this graft. Having tenting screws and eventually placing so much bone that looks like this, truthfully, somebody is getting frustrated intraoperatively and just trying to put a lot of different things to make it work. And sure enough, if you look at the case, see what happens to it. And by the way, I must tell you, I'll tell you from now, I am not a believer of autogenous bone, and we'll come to that and we'll have that discussion. And you can see that eventually, actually, the patient didn't gain anything. I'm sharing this case with you because it is all about your thought process, about how you see the case, and what is your ability to make a decision intraoperatively. What is it that you really need, and how can you execute? So we took the case over. You can see a small remnant of the block graft over here. We're trying to build the ridge to its original form if we can, and sometimes we are successful, and I'll tell you when these times are, and other times are not. But it is all based on stability, containment, barriers, and all of the fundamental techniques of guided bone regeneration that probably all of you are very familiar with. And we took this patient from here to post-operatively to that level in a very predictable way. But what allows us to get there, it is not the mechanical event. It is understanding the biology and understanding the anatomy and physiology of that patient. And ultimately, we end up with a ridge that now you can go ahead and do the implants. Because truthfully, I'll tell you what I think of the implant today, after 25 years of working with implants. It is not more than a mechanical event. The day that you are placing your implant, it is purely a mechanical event, and all the thought process should have happened way before you have done it. Unfortunately, I think you probably see similar things like this in Spain. I still see patients that come to my practice like this. And where is the dentist not thinking carefully about the case? Look at the muscle attachment over here. Look at the level of recession. It is a thin biotype, so we have to be very careful and we have to be very cautious with that type of case. Does it really work, and can we compensate for it? And the answer is yes, and we will show you how. But also, when we think mechanically, we have to give credit to somebody that's trying to do something like this. He is a pure mechanic. From a mechanical perspective, somebody was trying to be creative. And truthfully, this is far from being good dentistry and or scientific in any way. I also, believe it or not, being in an incredible place in proximity to New York City, where there is great talent like you have here in Spain, I get to see this patient that has been walking around with this dehiscence over here. She has one implant, and obviously you can see there's a lot of other problems with the case. And she has seen multiple specialists in New York City before she came to us. And her dentist is asking me, can you close over this portion of the implant? And if you look on your CT scan, clearly there is very little bone in this entire section. And my answer is, we can do something. But if we think for a second, this is following orthognathic surgery, following orthodontics, and multiple procedures. So I understand the meeting is an interdisciplinary meeting. And I can tell you, there is no more interdisciplinary that can happen than this case. But where did we miss some of the thought process? That you place your implants and you almost don't think about it. You go ahead and you do some orthodontics. Do we know the effects of tooth movement on adjacent implants? Have we researched that particular topic? Have we looked at it or attempted to understand? Or sometimes the orthodontist or us, the ones that asking for the ortho, well, I only want you to move that tooth, one tooth. Like in this case, they just wanted to expand this area here. Actually, these implants were not dehisced before. The patient had the implants actually for about 10 years without soft tissue dehiscence. So, but when you think that we are going to do something and we cannot fully comprehend the impact that it has on the arch and the adjacent teeth, that's when we get stuck. And that's when I will keep repeating it. It is the forward-thinking concept. Yes, we can expand over here orthodontically. Would it have any effect over here? And now I don't know for sure that the orthodontics is what got us to here, but think of moving one tooth will have an impact on the entire arch because one tooth is attached to an entire arch. So now we take this case, and I'm going to tell you the mechanical event, what I did, because it is purely mechanical at this point. My thinking is if I go over here, my fear that the segment of the maxilla could be dislodged. So I decided, you know what, she's not going to have implants. I'm going to section this implant right over here in this direction here. So I eliminate all of this. And could I potentially close it? So yes, there is a mechanical event, but there is a biological event that should get me there. And the biological event that this tissue is healthy, this tissue is healthy, I have thick tissue here, hopefully it will all come together. And that's what I did. Her dentist actually is a very talented restorative dentist. He temporized her because we needed to take everything off the implants. And you can see here the day of surgery that I actually sectioned that implant. And the tissue will close predictably. And here it is, we have closed it. But that is not the end. Actually, I'm in the process of working on this case, and I've decided to share it with you. Now, how do we enhance the volume of the soft tissue? How do we go about dealing with the second implant that is already here? I can tell you, we already went after this implant because you can see this. Can we restore that volume of soft tissue to its ideal form? The answer is close to it, and probably as good as before. But I will not stand here and tell you I'm going to remove these two implants in hope that I can recreate all of this. And one condition we've put on the dentist, that no movement or no other work can take place on this case until we decide that it is. So it sounds more like a complication lecture than interdisciplinary, but believe it or not, complications are a result of a lack of interdisciplinary thinking. Complications will result as a lack of forward thinking. So you don't think enough of the case and you say, okay, I'm going to do it. So I'm shown this x-ray here and I'm told, what do you think of this case? And I said, you know what, I don't have enough information. Obviously, there is this position here that doesn't look very good. You know, here on the PA, you see it magnified and you see more. So few things will happen. Think about this. Don't look at this side here for a minute. Think why you would not see this implant over here. Yes, you're telling me, well, the position of the camera doesn't get you there. You're probably right. But I can tell you, I've tried many times when I ask the patient to open her mouth. This implant I would not see. Then think, what happens to the cheek on this implant? Is it a factor that you should consider? And we believe that it is yes. So from here, we tell the restorative dentist, please temporize the patient. And you can be critical of the provisional. It may not be the most beautiful provisional. But nonetheless, now we prevented the cheek from coming into the site. And we can see that this implant is a hopeless implant. If you look on your CT, and I think in this day and age, if you're doing anything without enough diagnostics, maybe you shouldn't be doing it. So we can see that this implant here is totally in space. And the second implant has lost a very large amount of bone on the buccal side. So clearly, these implants are a problem because we saw from the beginning that the influence of the cheek and the position will get them there. And of course, the arch form is totally wrong over here and needs to be corrected. So what are the things that you need to look at in order to make some assessment? Biotype is one. We need to understand the tooth and tooth position and angulation. Position of the adjacent roots if you are dealing with partially edentulous cases. And I know that some of you here will focus a lot on the presence of buccal plate. And I understand, and I respect that. For many years, I was very attached to what's so-called the buccal plate. The last speakers mentioned the socket shield, which I believe is a very good technique, and I think it should be one of the tools that you have in your toolbox. But think for a second and keep it in the back of your mind, and we'll come back to it. maybe having a buccal plate a limitation. It may not be the best opportunity that you have. It might be one of the problems that you're subject to in your ultimate success if you're careful with that. Proximity to anatomical structure, you're all very good at this. The macro and micro implant design, you're all selecting an implant that you're feeling comfortable with and that you can place. Abutment design and material, that's a very important topic because whatever we do to that abutment could influence positively or negatively what we do. And one last part we'll talk about is the perioral muscle action and how that influences your success or your failure. My goal is to always be here. I never want to go into sites that look like this. Because if it looks like this with the soft tissue, believe me, when you expose the site, it is more deficient and more limited in volume, and you will have to work a lot harder on it. So you wonder, the patients come to us like this, and believe it or not, one of us, maybe not in this room, but clearly not in this room, that treated these patients, but we do this kind of challenge to ourselves. When we take teeth out, and we don't think enough of what are the consequences long term, these are the sites that we end up with. The patient didn't come to us like this. We create these defects, and we have to think of how we overcome these and not allow them to happen. And of course, another thing that I am totally against is this kind of thinking that, I place the implant where I have bone, and eventually you'll deal and you'll manage with angulation. Our implants, they're totally in the center of the anatomical tooth or the clinical crown. I'm not opposed to cementable or screw-retained. Each one of you might have different preference. That's for you to decide. But let's talk a little bit about immediate implant placement. And this is a topic that actually, I must say, I explored it in the mid-90s by accident, just because I was somebody that always rejected what we are doing today. We have to do something better tomorrow. So in our environment, when I was at NYU, doing an immediate implant placement, you've almost like you made a sin, and somebody will take you to jail, or the priest or somebody will penalize you for it. So this case was done in the mid-90s, and what we had is a probe. We actually didn't even have a CT scan to actually do the case. And then we eventually became more ambitious, and we started to do cases similar to this. The idea here, look, when we took the teeth out, the ridge totally collapsed. And all of you probably have that tremendous knowledge, and you know that about 40 to 50% you would lose in a very short period of time. But if you look at where we have restored the case over here, that dimension buccal to the canines was maintained. And I'll share with you how we do that. So let's start with biotype. It is extremely important that you take it into consideration, because biotype will lead you to some very critical factors. You know already that you have a thin buccal plate. So for those of you that you believe it is important, that's a limitation. If you think the way I think, that may not be an obstacle. But where is the obstacle in thin biotype? The tissue is very scalloped and is also very thin. So while I'm not worried about the buccal plate, I have to have the thinking of how do I compensate for that thin soft tissue, because if you are very close to the buccal, then you're going to have a gray hue that comes through your soft tissue, just like you saw in the earlier case. The presence of the buccal plate, and as I said, I'm going to tell you from now, for me personally, I think in some cases it is a limitation, and if you don't have it, it might be a great opportunity, and I'll show you why. So does an implant placement prevent the buccal plate? And I do apologize, I don't know the name of the last speaker, and he mentioned Giuseppe Cardoropoli and the Lindy team about the bundle bone and what happens there. So that type of research has been around for a long time, and it is a tremendous research. And from a basic science perspective, we should all embrace it and learn it. You need to know what really happens on a biological level or a cellular level when you take a tooth out and you place an implant over here. So for many years, we've all quoted this article by Arojo and Lindy, that if you took this tooth out and you place this implant here, we know that this bone eventually will be lost. We have the histological evidence for it. That's what you all believed. Or that's some of you still believe that today also. So here are two things that we have to take into consideration. One, that the beagle dog is a thin biotype. So we have one problem. Not that the bone is very thin, that the soft tissue is very thin. So how do you compensate for that soft tissue thickness? If we believe that this bundle bone will never stay there, then we accept that. Then we have to look at what happens post-operatively or following histology over here. So we can see that this bone was totally lost. But if I showed you this image here, right? This is what we saw before. And look when we superimpose the implant to that site. That implant is very wide. For the experienced clinician in the group, I would bet that they would look at this and they'll say, you know what? This implant is very big, and yes, you lose the buccal plate of bone. And you've probably lost it during extraction or during implant insertion. So you really don't have to depend on this histology to get you there. So how do we go from here? So there are a few papers, and some of the people actually probably also here in Spain. I'm mentioning this paper by Belzer and others just because it's important that you think and you have an understanding. While I'm telling you the buccal plate may not be your greatest friend, but you need to understand how thick it is if it is present. And it's about 0.5 millimeters, so it is not a huge amount of bone that you're looking at. Later on, also through Lindy and others, we started to talk about the possibility of having a thicker buccal plate. And I can tell you, you might see it in some patients. There is a thick buccal plate in some patients, and you might be able to do a lot of great things there. But it's not that often. It's not that evident all the time or that present. So you have to compensate for it. But also in 2010, Lindy and the entire group started to say, well, you know, maybe immediate implant placement can work. Maybe you need to graft. And the answer is yes, immediate implant placement can work. You definitely need to graft buccal to that implant, and you also have to think of the volume of soft tissue that you are working with, because alone it would not work. So these are the papers that will actually highlight this. As far as implant design, I can tell you I've learned also over time to compensate for the style of the implant if I needed to use something different. So over the years, I've experienced about 20 different implant systems in depth, because I've used a large number of all of them. And I must tell you, I do have some preferences, and I have some directions that in my head that I believe in. But I'm not here to decide which implant that you can use. It's very hard to actually find a bad implant anymore. The implants are very good. Abutment design and material. While this is what the companies provide you, there's a large component that really falls into your lap, you as the dentist. So case in point, I get this case over here, and you can see that it is a compromised tooth. We definitely don't have a buccal plate. And as I said, I really think it is an opportunity and not a disadvantage. We place the implant, we recreate the buccal bone over here. But what do I want to focus on is the thickness and the profile of the soft tissue that we have created. While also, in short, in not using the forward-thinking concept, I've decided to place the implant not thinking or paying attention that this patient should have orthodontics. So later on, after 1 year later, after I placed this provisional here as an immediate temporization, she decided to have orthodontics, so I have to do things differently today. So yes, you can design using CAD/CAM. Yes, you can have a very good technician that you work with and understands your thinking. But what happens when all of this comes to the chair and you have a limited results in what you have in using a provisional? So abutment design, you as a clinician, you can design it on your CAD/CAM, or you sit down in the lab with your technician and you ask your technician to recreate all of this chair side. And that's what we have done over here. Don't focus too much on the shape of the provisional over here, because really that's not what I'm showing it to you for. Look at the quality of the soft tissue here. In a case that did not have a buccal plate. But what we did is recreate buccal bone. Look at the arch form that we have created over here and over here. We have recreated buccal bone, and we also have enhanced the volume of the soft tissue. That's what we need to do. This part here, truthfully, I never take a credit for. This is a very good ceramist that eventually will do this work, and they should get the credit for. But I tell everybody, look, I'm still going to get credit for everything that we have done over here, because that's the work that we do. That's the separations between doctors and ceramists or technicians. And we do this for a lot of cases. So you can see this tooth here that is in a very challenging position. We recreate this. But also, again, here, the whole idea, it is you making the decision for where the soft tissue should be. Should you be concave here all the time? And some people believe that. And I respectfully disagree, because there are cases where you have to be concave. There are some cases where it might be straight or convex, just like the previous case that we did. But again, the whole idea here is, how do you maintain that complex? What happens here, truthfully, I'm a prosthodontist by training, and I don't do much of this work anymore. My primary focus is surgical interventions. So a very good ceramist will do the work, but you have to make the decisions and make sure that you're comfortable with what you are getting over here. I'm going to go back to that very first case that we saw earlier with the 2 implants here, and how we are managing some of these problems. Clearly, those 2 implants should be taken out. You've already seen the scan. And following removal of those 2 implants, as I said, we need to make sure that we have a fixed provisionalization here, because it is the only way that we prevent the cheek from invading that space and actually causing resorption on the bone. And we have recreated those 2 sites, as you can see here. And clinically, that's the ridge form that we have created. And the dentist will work and will get all the rest of the stuff done. But the idea here is, if you don't have a certain volume of bone, don't attempt placing the implants, because placing the implant is the least important event, is not actually that critical. It is purely mechanical. And if I don't know the group very well, so there are a lot of cases where you are in the posterior maxilla where you might attempt taking a maxillary first molar out. And you probably lose a huge opportunity there, because the opportunity that you have may be preventing the patient from ending up with a sinus complication or the need for a sinus graft. So this particular case here, as you can see, there is an oral enteral communication that the patient comes to us with. We've decided that we should somehow figure out how to close it. But if you think, how would you regenerate that sinus, right? Very thin cortical bone, if no marrow at all. From where would you recruit cells, and how do you actually eventually build bone? So you count on additional factors. If you're believers of using PRP or PRF or any one of those combinations, that's a great tool that you have. In our case, we use BMP2. I'm not sure that it is available in Spain or you use it. It is a growth factor combined with a bovine bone, and we actually end up doing the lift, closing the communications all at once. But even with this, we still have a deficient ridge. We go ahead, we place the implant, and we look at that defect that we see over here. And the defect as well should be corrected. Now, at this point here, whether you are using strictly particulate bone or you are combining with something else, is really your choice and your confidence or belief in what you can achieve. But you need a barrier, and you need to close that site, and eventually you restore the case and get the results that you want. So went from here to here, and eventually restore the patient as such. But you will see this often in the posterior maxilla. If you're taking a lot of maxillary first molar out, it is not an unusual event. And the illustration here is just to show you that eventually what we need is to figure out how we recruit cells to come into the sites. And the only method that we have here is using something like BMP2. It is a great tool to have. We don't use it all the time because of price and other factors. But here's what I want you to pay attention to, that every time that we are taking a maxillary first molar, or you have a maxillary first molar with very divergent teeth, the minute you decide to take it out, you have to understand that the sinus actually is filling that radicular space. And when you take the tooth out, you have one opportunity to save it, maybe an immediate implant placement, or possibly figure out how you prevent an oral anterior communication. It is an important tool, and I think you should look at it very carefully, because that's what will cause a sinus graft and a sinus complication later on in that part of the mouth. So if you look, I'm just showing you here, actually, this is a dentist that was doing the mentorship program with us. Even for tooth number 15, what we are doing today, and is one technique that we believe very strongly in, and in our database, we have about 1,500 of these cases. You can see that there's a communication on the buccal side. There is a communication on the palate side as well. Can we take the tooth out? The answer is yes. Should the patient have an implant? It is a decision that you and your patient will have to make. It is our protocol today that actually every time we take these teeth out, an implant actually goes in that spot the same day. We have to understand how to isolate the sinus and how to prevent, obviously, the implant from going in, creating enough bone around it. Fill the entire space. So we'll come back to that, because the only way that actually you'll end up with buccal bone is you create the space and you fill it with bone and you isolate it. You use a barrier. And if you look at the post-op CT, if you are able to achieve this on maxillary second molar, I think you have a huge opportunity to look at this for almost every tooth. So what would be my advice for you? Maybe not, your case shouldn't be maxillary second molar or maxillary first molar, but maybe a premolar site. And attempt it, because it's a relatively benign site. You can treat it if things don't work very well. And try to isolate the soft tissue without opening a flap. Drive a membrane in and graft that entire buccal bone. If we have this, now I think we have a good formula for treating posterior maxilla predictably. And as I said, we have about 1,500 of these cases that we've done over the last maybe 5 years, and we're actually collecting our data. We'll be publishing on this, and hopefully we'll share it with you. So look at this case here. I think it's very clear that there is nothing happening there. So here one technique that you should actually use, because technique is important. So while you take the tooth, as you can see, there was a fistula also that is happening over here. It is not a difficult technique, believe me. Every one of you here in the room will eventually be able to do this predictably. You go inside your socket here, and you dissect, but you must dissect all the way here and all the way here without tearing your papillas. They must be still intact. So there are many different tools that you have in your surgical kit. You find the instrument that works for you. And it doesn't take time. The first time might take you a couple of minutes. Eventually, you predictably can go in there. And then you take this membrane, you design it. By the way, it's always the same design. For a single tooth, it always looks like this. And you drive the membrane in. And here it is, laying down. It should be laying down on the surrounding bone. It's not inside the socket. If it is inside the socket, you're not going to get what you want, because you just have a very limited space. And once you're already there, you flatten it out. You must suture it, because if it is not sutured, actually it will move around the cheek, and the lip will move it around, and eventually what you're hoping for to be an osteoblast will convert and becomes a fibroblast, so therefore you get a fibrous encapsulation of the site. You fill your site with bone, and that's what I'm saying. It might be an opportunity, because now you can build even more than you would need. And at post-op CT, you will see something that looks like this. This is a predictable event. You can do it every time. You just have to actually get to believe that buccal plate is not a limiting factor, that if you don't have it, you cannot do the work. Somebody should let me know the time. What time would you like me to stop? Okay, perfect. And you can see the soft tissue here. And again, I don't do this kind of work anymore, so don't ask me about the adjacent teeth. My job is to tell you what is happening with the soft tissue and the bone and what was created here. It happens for all of the teeth. If you don't have that buccal bone, you must graft it and recreate it yourself. It is in your hands. You are capable of doing it every single time. And it's one of the most unique opportunities. But here's another thing when you're looking at teeth and tooth position. Oftentimes we thought that this is the right position over here, right at the crest. We have a tendency today that we are placing implants probably 2 to 3 millimeters below the crest in most cases. And that's the one way that we eventually learned and found that we can manage the anatomical or the clinical crown much better. We can create better support for the soft tissues. And again, it's somewhat of a controversy. Some people think that you have to be at the crest. We have also a very large data in this, and we believe that it is the case. This is probably why I came here. I really wanted to share with you this kind of thinking. It's the perioral muscle action. It is a diagram that's showing a few different things here. Keep focusing on this one here. Once you have a tooth, this is your lip. The lip cannot exert any force on the buccal plate or the cervical soft tissue over here. If you take your tooth out, as we can see here in this side, and you do nothing, because many dentists, even in the United States today, take teeth out and don't do anything. That site, we know that will be compressed, and you lose about 40, 50% in short period of time. If you grafted it, you have a good opportunity to maintain it. It is not 100%. I can tell you, I've done a lot of extraction socket management. I rarely get 100%, if ever. Maybe 90% of the volume. And then I have to go and enhance for it. And that's okay. It's not a bad thing. If you place the implant and you don't temporize it, the key here is to fill that space. And if you fill it, you might compress it a little bit. The most ideal is to immediately temporize it. Now, I'll tell you, I have not immediately temporized a single molar, but premolar forward, every implant that we place, if it does have high initial stability and we work very hard achieving that, it is temporized because that's how we find that the quality of the soft tissue is actually a lot better. And also this data is already in preparation for publication as well. So why forward thinking? Why do we have to think of these cases and think differently? You're treating some of your patients at a young age. Do we know what happens to them over time? Do you know what happens to their medical history? Do you know what happens to their bone metabolism? Do you know what happens to their physiology? Do you know what happens to their muscles and muscles of mastication? And it's all of these things that you have to take into consideration. Do you know if your patients are deficient in vitamin D and what impact could it have on bone and bone regeneration? So it's all of these things that you have kind of to put together. So what is that formula? Because probably like many of you, one of the most frustrating events for our dentists is when you do things and things don't work. So I worked for so many years on trying, what is it that I really need to put together to be successful most of the time? So here's some of my thinking. I used to give myself a lot of credit that I'm a great clinician. So that's when things work. And I didn't put too much emphasis on the patient. The site, each particular site within the patient that you're working on could be different. The products are very important. And the science. The challenge is when things didn't work. Now I'm trying to explain to the patient that maybe they're not healthy, maybe they're smoking, maybe that site is challenging, maybe the product that I'm using was not the greatest product, or maybe the science that I was using as a reference to support my decision making is not great science. And the reality it is we are somewhere between here. You know, I still feel that I'm a pretty good clinician, just like most of you, but I put a lot more emphasis on all of this today. I put a lot of emphasis on the patient and the site that I'm working on. I'm spending more time understanding medical history, and medical history effects on the patient, and whether they take supplements or they don't. And can I make them better in that regard? So we'll come back to that very first case. So you thought he only had one problem on the lower, but he has a bigger problem on the upper, and that's how this patient came to us. You can see the recession. Somebody tried to do some type of free gingival grafts over here, so I cannot be critical of the thinking. Somebody is trying. But we are trying in a mechanical direction. We are not trying in a biological sense. So what we did, I took the teeth out first to show you that, yeah, the teeth can be taken out. The tissue looks like it is here. But you can see that each one of the teeth did not have a buccal plate. So we placed the implants. A very large portion of the implant does not have bone. We build the bone, as you can see it over here. And then we are enhancing the volume of the soft tissue because, remember, this is thin biotype. So we have to recreate that environment first. So we place Alloderm. I think it is a product you might have here, or Dermis from Zimmer, and there are others, I'm sure. But these are the two primary products that we use. And we're having the patient actually wear an Essex device, and you can see it is applying some pressure here, so his dentist relieved it a little bit. And eventually went from here to here very predictably in one surgical intervention. We go to the maxilla. Somebody had already placed implants for this patient. You can see the dehiscence over here. And this event is purely a mechanical event. Just somebody puts a couple of screws in somebody's jaw. I grafted it for the first time, and it still was deficient, so I wanted to enhance it here. So at implant placement, I'm enhancing the ridge. And the dentist that treated him is Stephen Hudis. Those of you that come from New York, you probably know him. He's a prosthodontist teaching at NYU. This is the wax try-in, and we took this patient from here to here in very predictable way and very successful. So how does this forward thinking actually is impacting our treatment planning? So we have decided that there are a few things that we need to do differently. So there are replace, reduce, and redefine. We want to replace concepts and beliefs. You know, somebody says, this is the way we've been doing it for 50 years. You know, if you don't have a buccal plate, you cannot be successful. If you do immediate implant placement, it's not successful. So we've rejected a lot of that thinking, and for almost 20 years, we've been doing immediate implant placement and temporization. My primary focus is what I call reduced morbidity and the treatment time. Those cases that you take in your offices and you're treating for probably a year or year and a half, I think we make a mistake, because to be successful in a case in treatment for a year and a half makes it very challenging. And sometimes we pull it off. But can I treat the same case within a period of 6 months, 6 to 8 months max, between extraction, grafting, immediate implant placement, and to final case? And I think that's key to success. Redefine knowledge and new standards. And I don't get stuck anymore, and somebody told me autogenous bone is the gold standard. It is old thinking, truthfully. It is the old standard. It is not the gold standard anymore. So let's take a look at this case where also when I was at NYU, and those of you that are present here, so that case used to take us maybe a year and a half to pull it off, and now within 6 months, I can get this case completely done and organized. So that's how the patient presents to us radiographically. We know that all of these are hopeless. This is a compromised tooth. This is a compromised tooth. So we're left with 3 teeth. Some of you can also be critical of my thinking that I'm taking some good teeth out, right? So these teeth, you might look at them and say, come on, you're taking good teeth out to put implants in? But also I have to think of the patient's life, right? You know, somebody is 65, 70 years old. How many times I want to go back and do full mouth rehab on that patient and keep her in treatment? The lower is the same thing. So we go in, we take everything out. And by the way, this is not CAD-CAM generated. We do a lot of digital planning, but we also work with some very good technicians that have the ability to understand and connect with our thinking. So if you're thinking over here, look at every embrasure space that we've created, every emergence profile of every tooth. And you know, sometimes technicians might overlook something. So something like this, we will have to correct the chair side. And we took the patient from where you saw her to this in one surgical event. You can see that we have some challenges here that we have to address the soft tissue. We have some things going on over here. And also you can be critical as well. Look, you can have better papilla over here. All of that will come. But just imagine where the patient was and where we took her from, and all of these teeth. This is an implant, this is an implant, this is an implant, implant as well. Same over here. And eventually, I'm working with also a very talented dentist that she started to work and opening the embrasures and creating more space to enhance the soft tissue, trying to close some of these things. But as I said, a case like this, within 5, 6 months, 8 months max that we want to begin and finish. We don't want to spend more time on that. We're already in the process of working the lower, so you can see how this is already changing. This is actually the hard work. This is the finesse of the restorative dentist that is willing to spend more time. You know, I almost feel like I've done the easy job, and someone is really working really hard to get this. And you take somebody like this. You know, some of us that have done a lot of restorative cases realize that maybe sometimes when you play a lot with occlusion, you have such challenges and you may not be able to do certain things. So look at the level of breakdown. The patient is in his 70s. This tooth is hopeless. These are on the way. So we designed the provisional, and again, it's a combination of digital and skill. You know, when I talk with our technicians, they tell me, if you want us to lie to you, we'll tell you it is 100% digital. If you want us to be honest, it is about 50 digital and the other 50 is art and skill. So we have decided that we want to level to the canine teeth, right? So we need to change all of this over here. It is all done pre-operatively. Patient comes in, we take the teeth, and I agree with you, they're very good teeth. You know, how can we take these teeth out? But how can we make this patient function predictably for long term as well? So these are the implants that go in. And look, when we are somewhat aggressive with our management of soft tissue, what we see post-operatively. So this is at 3 weeks later, the patient is being challenged with healing and is getting a little bit better. But nonetheless, that's where we brought the patient. Look at the arch form that we've created over here. And his dentist just sent me a picture just before I left. This still needs to be refined and worked on as well. But maybe we need to redefine actually what osseointegration is, because when you think of all of these that we're doing, they're really different than what we were told before. Allow the implant to osseointegrate, don't put unnecessary load, and we're being very aggressive. I don't believe it's actually controversial. It's the only way that we will get better and we will move forward. As I said, for immediate implant placement, my feeling is, regardless whether you have a buccal plate or not, if you have the skills and you know what you have to do to manage that site, I think you should do it and go ahead to achieve that. But also look in the sites. Every site is not the same, so don't believe that because I told you just take the tooth out, if you have no buccal plate, you'll be successful. Remember, you must examine the site for its own merits, for its own regenerative potential, and would it be successful? It is very rare that you're going to see this type of case, and I show it as a joke because, you know, yes, you can place implants, you can fill the bone around them, and this patient heals. That's a unique patient. If we all have this kind of patient every day, we'll all be very rich, we will all don't work very hard, and we will not actually have to think very hard either to get there. And I would really leave you with this. Even with no buccal plate, my job is to always recreate this. And I can tell you, today, my understanding of the site of the patient, analyzing all the factors that I need to look at, I can do this with very predictable results, almost recreating a neocortex over here to achieve this. This is one of my favorite quotes. Look deep into nature and then you'll understand everything. You know, we run to get into the mouth and we never look at the patient's face and cheeks and what is it that is happening to them. If you look at this illustration and you see what we have done just to analyze the face, what happens to the face? How does it behave? Are the lips working with you or against you? And all of these factors that you have to take into consideration. I won't to thank you for the opportunity. Jaime, it has been a great pleasure being here. I hope I did not keep you here too late. Thank you very much.